Today, you'll hear about the physician's role in safe implementation of the 10 steps. This program is part of the Maryland Department of Health and Mental Hygiene Hospital Breastfeeding Policies Physician Webinar Series. After completing this presentation and successfully completing a post-test, physicians will receive 1 hour of continuing medical education. This CME will be available through June of 2019. DHMH thanks LifeBridge Health and Dr. Dana Silver for partnering with us to make this possible. Per DHMH policy, we remind our listening audience that the recommended steps to reduce contracting the Zika virus, which can cause serious birth defects. Citizens are advised to avoid mosquito bites, use insect repellent, and empty containers of standing water. This slide pictures the species of mosquito that spreads the Zika virus. This final slide on this set shows websites that you can access to find more information. Now, having gone through those slides, without further ado, I want to move to our presentation of the day. Your speaker today, Dr. Lori Feldman-Winter, is Professor of Pediatrics at Cooper Medical School of Rowan University and the Division Head of Adolescent Medicine at the Children's Regional Hospital at Cooper University Healthcare in Camden, New Jersey. Dr. Feldman-Winter is recognized around the world for her work related to breastfeeding education programs and nutrition policy. She was the physician champion of the New Jersey Baby-Friendly Hospital Initiative, a project of the American Academy of Pediatrics New Jersey chapter, and the New Jersey Department of Health chair of the policy committee for the AAP National Section on Breastfeeding, and was national faculty chair for the National Institute for Children's Health Quality Best Fed Beginnings Project. She currently serves as AAP representative to the United States Breastfeeding Committee and is a member of the AAP Task Force on SIDS. She is a consultant and physician lead to the Kellogg-funded Communities and Hospitals Advancing Maternity Practices, otherwise known as CHAMPS project, and the New Jersey Hospital Association's Mother-Baby Hospital Initiative, Healthy Beginnings of New Jersey. I'd like to now welcome Dr. Feldman-Winter and let her take over.
Thank you all so much, and thank you for that warm introduction. I'm really delighted and excited to be able to present to all of you today some tips from our recently released clinical report from the American Academy of Pediatrics regarding safe sleep and skin-to-skin care, which addresses some of the other steps of the Baby-Friendly Hospital Initiative as well. So appropriately, today's talk is entitled The Physician's Role in Safe Implementation of the 10 Steps. So again, thank you so much. Hopefully everyone can see my slides now, and we'll get started. The learning objectives for today are to explain the steps to advocate for evidence-based practices that support exclusive breastfeeding and delineate the risks and the benefits of the 10 steps and the Baby-Friendly Hospital Initiative, and then ultimately both define practices and adopt practices that support simultaneous implementation of the 10 steps while adhering to safe sleep guidelines. So let's first start with just an introduction about breastfeeding, because really the 10 steps to successful breastfeeding was introduced as the methodology to increase breastfeeding. So why is it so important to increase breastfeeding? Well, if you look at the left hand of this slide, we can think about the nutritional components of human milk, and as you can see, they completely outshine all of the factors that may be included in infant formula or a breast milk substitute. But really beyond these nutritional components are the health outcomes, which are illustrated in part on the right hand of this slide. And really it's because of the nutritional components that we've identified, those that we don't even know about, things that aren't even mentioned on this slide, such as all the different factors that lead to the development of the normal human microbiome, which really contributes to the lifelong health and well-being of human beings, leads to all of these health outcomes related to breastfeeding. And the health outcomes are in babies and children as well as in their mothers. And it's because of this that the health outcomes that are related to breastfeeding, that the 1,000-Day Initiative was launched, recognizing that the nutritional exposures, both in utero and during the first 2 years of life, have lasting effects. In fact, the foundations for health throughout the lifespan is largely set during these 1,000 days. Yet, globally, only 38% of infants are exclusively breastfed to 6 months, and in the United States, this rate is merely 22%, as indicated in our most recent release of the CDC report card. This rate is rising, but it's still far too low to achieve the nutritional benefits that are recognized through this initiative. And beyond that, we know that mothers don't breastfeed as long as they set out to. In fact, over 80% of women actually want to breastfeed. Many of them actually do get started, many of whom actually deliver in hospital settings. However, 60% of mothers, more than half, don't reach their breastfeeding goals. And they don't reach them because of factors that are, in fact, modifiable, things that we can fix, things that we pediatricians, maternal care providers, obstetricians, gynecologists can all work together with our colleagues in lactation and nursing and dietetics to help mothers overcome these very common problems, reasons why mothers stop breastfeeding. And in a study that's very often quoted because I think it's so dramatic in its effect by Girolamo, looking at the dose effect of the 10 steps to successful breastfeeding, those that are captured by the infant feeding survey, it's shown that for mothers who have delivered in hospital settings where there are no steps in place, so none of the 10 steps are implemented, 30% of those mothers are going to stop breastfeeding within 6 weeks. But in a dose-responsive fashion, for every step that's implemented in that hospital setting, that rate of cessation of breastfeeding declines dramatically. And when 6 of the 10 steps are implemented, only 3% of mothers will stop breastfeeding within 6 weeks. So a dramatic decline. So then what is the Baby-Friendly Hospital Initiative, and how does this relate to the 10 steps? Well, the BFHI is really a quality improvement project. Many hospitals are undergoing quality improvement projects for a number of different issues and conditions that we know are evidence-based, and practices, that are continuing based on tradition for the most part, really are now being examined and modified and changed to uphold the best evidence. And this is really where the Baby-Friendly Hospital Initiative comes from, is really looking at the evidence, establishing these steps, and now developing a program of quality improvement that really is going on in a global fashion. It is administered by the World Health Organization in collaboration with UNICEF, and each one of the countries that participates has their own designating body, a nonprofit organization. Many are conducted through the health departments, and in our country, it's conducted through Baby-Friendly USA. So how do you become a baby-friendly hospital? Well, by implementing these 10 steps. And I've summarized these steps, although each one of them are quite complex and have many sub-steps. But essentially, hospitals should have a policy that describes that they embrace the 10 steps. They should educate everyone that cares for mothers and babies about this policy, and so the education should involve not just knowledge but skills. There should be prenatal education. Really, all mothers that are delivering at that hospital should be educated well before their delivery date, so that they can expect what the 10 steps will actually look like and feel like for themselves and their families. Skin-to-skin care, really this step was breastfeeding immediately after delivery, and now the real goal is to get every mother baby to have skin-to-skin care, and I'll come back to that. Showing mothers how to breastfeed and how to express milk if they're separated, not supplementing and really upholding the code of marketing for breast milk substitutes, and not accepting free formula or marketing materials, rooming in, keeping mothers and babies together, recommending that babies feed in a cue-based fashion, and we now recognize that this is important not only for breastfeeding babies, but even bottle-feeding babies. It's important to recognize babies' cues and not to overfeed babies early on. Not introducing pacifiers or artificial nipples, which interfere with the establishment of breastfeeding. And finally, providing discharge support, really referring to those community support organizations, referring to pediatric providers and maternal care providers to provide ongoing support for exclusive breastfeeding. So how does it work? Well, in a recent systematic review done by MUN, looking at all the different impacts of the Baby Friendly Hospital Initiative in the United States, these are the factors that were identified. And I've added in italics some of the things that weren't even examined in the systematic review that I think should be considered as well. So let's go through this. We know that implementing the Baby Friendly Hospital Initiative, or the 10 steps, increases breastfeeding initiation overall and exclusive breastfeeding. Also increases breastfeeding duration, as I suggested earlier with the DiGirolamo study. But what we're finding also in some of the work that we're doing in the southeast of the United States, where breastfeeding rates are, traditionally are very low, is that by implementing the BFHI, we're actually decreasing disparities in breastfeeding. So we're finally seeing a way in which we can close the gap. And these disparities exist for race, ethnicity, but also for economic disparities and other disparities as well. There's provider factors that, as I mentioned, training is such an essential component of the BFHI. Education such as this one, but really on-site skills-based training is almost a no-brainer. Why wouldn't you want your practitioners to be knowledgeable and skillful in breastfeeding care when they're caring for mothers and babies who are, for the most part, breastfeeding? And so that documentation of proficiency and skills is really one thing that I think the BFHI does that has yet to be systematically identified or studied, but we know from being out in the field and seeing the skill levels of all the different disciplines that participate in care, that really is one of the main reasons why mothers are able to achieve their breastfeeding goals. The hospital and organizational factors, every hospital now is under a microscope for many reasons, primarily because of the Affordable Care Act and all the different requirements that go along with that for improving quality, improving patient satisfaction. We know that there's a dose-response relationship to the 10 steps in breastfeeding outcomes, but I would submit to you, I think MUN could have gone further to really look at the quality indicators that are being scrutinized these days and look at patient satisfaction scores as hospitals implement the 10 steps. In addition, has had in place for a while now a mandate that all their accredited hospitals report out on PCO5, which is exclusive breast milk feeding, for all newborns that qualify for breastfeeding in the hospitals. So even the Joint Commissions is looking at quality measures as it relates to breastfeeding and all the different care models that support exclusive breastfeeding. System factors, And these are really things that I think, again, go beyond what was reviewed in the MUN study, but I know that in the process of our Best Bed Beginning project, we had many hospitals that were newly adopting their electronic health record system. They were trying to figure out ways to capture what was actually going on with the 10 steps, and in doing so, by putting the practices in place, working with their IT departments, and really upholding best practices for documentation and for the creation of EHRs that could actually drive better care, drive evidence-based care. We believe that the EHR actually helped enable the integrity of the implementation of the 10 steps in a better way. And the United States Breastfeeding Committee, USBC, actually participated in the creation of guidelines to go along with the HITECH Act for EHR companies, which have yet to be implemented. So I know there's opportunities for the companies that create electronic health records for hospitals to do a better job in creating windows and screens and methodologies to be able to capture each of the 10 steps in a more organized and more automated fashion. So let's talk about the risks of not becoming baby-friendly, because I think we have to identify first that there are indeed risks of not implementing the 10 steps before we then talk about the risks and how we can eliminate some of those risks by safe implementation. So as I mentioned, if you don't implement the Baby-Friendly Hospital Initiative, your hospital will have lower breastfeeding rates, and all those things are being tracked for a good reason because it's directly related to health outcomes. So the CDC is very vested in tracking breastfeeding rates by state and breastfeeding practices and baby-friendly practices via the MPINC survey. So every hospital is surveyed every year, or every couple of years, every 2 years, through the CDC, and the reports are generated by state through the MPINC survey. We know that in hospitals that are not implementing the 10 steps, babies are cohorted and spend a lot of time together with other stranger babies in a big room, often called a nursery, and in that nursery setting, it's not all that benign, even though we've been doing it for a very long time. There are problems. There's infections. We have outbreaks of infections such as MRSA all the time. There are definitely security switches that can happen with babies. They all kind of look alike in a lot of ways, and so when they're caravanned out to their mothers, there's definitely possibilities for babies being switched. In addition, what we found in our hospital setting is when we made the transition to do rooming in care, is there were things that mothers were doing in the everyday care of their newborns that were in some ways alarming, and we would never have known that the mothers were going to be doing that without having that opportunity to witness mother care or paternal care or other family member care, support person in the room caring for the baby. And that's an opportunity to intervene and have the staff actually provide education about safe care of the newborn. So we really take advantage of having this window of opportunity to look at how the mom and family are going to care for this baby. There's definitely risks of code violations. Many hospitals in the United States continue to distribute infant formula in the way of the gift packs, and those gift packs have samples of formula that are not tracked. So if there's a recall, you have no idea whether or not a baby was exposed to that formula. In addition, we know that there's brand loyalty and that mothers very often revert to supplementation of breastfeeding if they're given sample packs or samples of infant formula. Staff training, as I said earlier, is kind of a no-brainer. You wouldn't want your staff to be deficient in training and skills in order to manage breastfeeding, given that most mothers 80% or more mothers in the United States are breastfeeding. And it just doesn't look good on patient satisfaction scores, but it really isn't good care when we're giving inconsistent advice, where you have multiple care providers saying different things. And the more you can train in an interdisciplinary fashion, we do interdisciplinary skills fairs at our hospital, then the more everyone can get on the same page and have consistent messages. And that's really what moms and families want. There's inequity. As I mentioned, we went to one hospital in the Southeast where 50% of white women were actually doing skin-to-skin care, which was interesting because there was no policy. They were just, they had heard about it, thought it was a good idea. And none of the black women in this hospital were ever getting skin-to-skin care. And we said, well, why? And the staff said, well, women get it when they ask. So this just is something that shouldn't happen in the healthcare system. We shouldn't be delivering care only when families ask for it. We really ought to be delivering evidence-based care in a manner that is not discriminatory. It's amazing, even in the prenatal setting, how much education is provided based on whether or not staff think that the mom is interested in breastfeeding, as opposed to just really expecting that moms are going to be interested in breastfeeding and providing that education. Separation during the golden hour. So very often what we see when we go around the U.S., and this happens in many hospitals, is that babies are kind of whisked away from their mothers right after delivery. And what happens when a baby is taken right away to the warmer bed, or even warmer bed in that nursery, is that babies cry more, they have more problems establishing breastfeeding, more problems establishing temperature regulation, which is why they end up on a warmer bed with a thermal probe for a really long time. And we know that that actually leads to more hypoglycemia. There's also some really interesting studies looking at maternal fMRI scans that are actually changed when babies are permitted to stay with their mothers during this golden hour. So which of the steps raise concerns? It's really the skin-to-skin care, and I'll explain why. Rooming in, having mothers and babies together continuously throughout the delivery hospital. Some issues related to staffing and security, and then definitely there's confusion related to discharge instructions. So I'm going to go over those particular steps. So step 4 was originally worded, help mothers initiate breastfeeding within an hour, and that quickly was recognized as probably not the right focal point, because if the focus is on just placing infants, healthy infants, skin to skin, then breastfeeding will happen. So on baby's own time and mother's own time. But that skin to skin care has to be uninterrupted, and the baby has to get there immediately. So the baby should be permitted to take their own time and to snuggle, and mom to get to know her baby. And that this should really apply to all different types of deliveries. And certainly if moms are awake and able to respond to her babies even after cesarean birth, there's a lot of great resources online that can be utilized to illustrate appropriate skin-to-skin care, even in the operating room after scheduled cesarean birth. It also applies to babies that are not breastfeeding. So even in formula feeding dyads, when there's a contraindication for breastfeeding, that's not a contraindication to providing skin-to-skin care. And that's because we recognize that the benefits of skin-to-skin go well beyond breastfeeding itself. So what are those benefits? And sort of the opposite of what the risks are that I presented earlier is that babies through thermal convection actually maintain normal body temperature from the mom. That supports a normal blood sugar, so babies are less likely to get hypoglycemic. It also promotes normal transition of their circulation. It takes a few minutes for that to happen, so this allows for normal cardiovascular stability, especially in the late preterm babies. And there's no real need to have the baby on a warmer bed to do all the procedures that we used to do there, such as assessment, stimulation, APGAR scoring, and definitely no need for test feeds. And I always put that in there because there's still many hospitals that won't allow babies to actually feed until they've had a, quote, test feed. But we now know that that's unnecessary, in the unfortunate case where babies, would have an issue with either a T fistula or some choanal atresia. It's way better to aspirate human milk than just about anything else. So, really, skin care can go on in an uninterrupted fashion. And when a baby is delivered, one of the things that sort of goes along with this whole procedure, if you will, of getting babies to skin is when to clamp the cord. And so sort of along with the movement of doing more skin-to-skin care is this movement to delay the cord clamping. I hate to call it delay because I think that makes it sound as though it's abnormal in some way, so I like to call it appropriately timed cord clamping. But what we found is that if the baby's delivered, the cord clamped right away, right before the baby actually gets to skin care. If the baby's then in skin-to-skin care, they're not going to be screaming, crying, as I mentioned. They're going to be more comfortable, and so they're going to have increased pulmonary vascular resistance. You're going to have less blood flow going through the heart, more right to left heart shunting, and just hypovolemia and hypoxemia in the brain, and that leads to problems. And so that may be one of the issues that are set up for what I'm going to talk about in a little bit. So, so appropriately timed cord clamping, you can actually place the baby on the perineum, initially allowing the cord to pulsate for at least a minute, as much as a minute and a half, and then finally clamp before allowing the baby to kind of crawl up to the mother's chest. And Neuromeier defined 4 really important points, and the first is just that the cord shouldn't be clamped until there's that transition to adequate respirations. The baby doesn't have to scream and cry, but they should definitely be breathing adequately, opening their lungs, so that there isn't this pooling into the lungs that would deprive blood to the brain from cord clamping too early. The umbilical cord clamping should occur before respirations occur, so the baby should breathe first and then clamp the cord after. And as mentioned here, if you clamp before, then because of that hypovolemia, hypoxemia, you get decreased heart rate and fluctuations in the cerebral blood flow. And something that I don't think most hospitals do, just something to consider, and that is to record all these things. So record the time after delivery to the onset of respirations, record the time after delivery to umbilical cord clamping. And then, this would be an area of further study, because I think that there's hypotheses that this contributes to some of the problems that occur. But because there's such little documentation of these specific variables, I think we just don't know. And then cord milking certainly is something that's done often in the premature and late premature population. There's some other hints from rat studies that have shown that in the first couple hours, as well as in conditions of cold stress, there's a longer time lag that occurs between the gasps of breath. So when these rat pups were not allowed to breathe and then challenged, depending on their postnatal age and depending on their core body temperature, there was a longer period of time. And that may be somewhat explanatory as to why babies in the first couple of hours are particularly vulnerable to issues that might arise. And breastfeeding in and of itself affects transition in ways that are presumably physiologic, but may cause alarm, in that when the babies are skin to skin, they may have a lower heart rate. In fact, a higher heart rate may be a reflection of a more abnormal state. They may have more shallow breathing, not crying so much, so their SpO2s might be a little lower. And so it's really about reestablishing the normal vitals and normal parameters for a breastfeeding baby who's skin to skin as being normative and really knowing when to worry. Skin-to-skin care decreases pain in the newborn, so it's a great place for babies to be if they need to have any kind of procedures like heel sticks after that hour, if they're being tested for hypoglycemia. And as I mentioned, it would lead to less crying and ultimately even better growth, better absorption of nutrients. So duration of skin-to-skin care is often called into question, and this is a nice study to show that, in fact, less than an hour of skin-to-skin care is not as good as the full hour. And this is a study looking at salivary cortisol levels in the baby. And there's a significant difference between the salivary cortisol level in babies who receive the full uninterrupted hour of skin-to-skin care as opposed to those babies that receive less than 60 minutes of skin-to-skin care. And then in the mother, mothers have also been tested with regard to salivary cortisol level, and it's been shown that skin-to-skin care is not just for babies, but actually improves the maternal stress level, actually decreases maternal cortisol levels as well, and enhances that opportunity for the first feed, which actually leads to better breastfeeding later on, more organized suckling patterns, and then ultimately more success in exclusive and overall breastfeeding. So the risks were really brought to attention when my colleague Jay Goldsmith published this article in AAP News, and really setting the discussion about balancing the skin-to-skin care policies and the 10 steps with safe sleep policies and things that would avoid events that could be problematic, and in particular, the event of sudden postnatal death. He also drew attention to the fact that after delivery, mothers are often sleepy or exhausted, and that in the rush to do skin-to-skin care without really efficient process mapping, mothers are often not observed during this period of time, and that mothers may be taking medications that add to the problems. And then he also included in here this issue of bed sharing, because often moms are seeing bed sharing in the hospital setting. So I'll address some of these factors. So what's the big concern? SUPC, sudden unexpected postnatal collapse. So there's been more and more publications in the literature about this episode, which is a sudden collapse in a previously healthy baby, essentially. That's 35 weeks gestation or greater. And as you can see, there's a lot of variability in the population studied to determine true incidence, but we think that the majority of these events are occurring in the first couple of hours. Some occur within the first couple of days. Rarely do they occur after discharge from the hospital, but it's really this condition that that has been identified in the first couple of hours after delivery. And so all the things that I talked about may be contributors. Nobody really knows. Just like with SIDS, we really don't know exactly what the cause is. But we have some hypotheses, and because of that, we're able to sort of gather some important pieces of information for guidance. And one of them is just a safe positioning. So it makes sense, babies being obligate nose breathers, they can have their nares be easily obstructed. So it's important that the face can be seen, that the baby's not completely smothered with blankets, and that the baby's in a neutral position, that somebody's really attending to the baby and actually observing. In the clinical report, you can see that we actually delineated sort of the procedure for immediate skin-to-skin care, which includes all the things that I just talked about with delivery of the baby, drying and stimulating, placing skin-to-skin with the cord attached, and then clamping after 1 minute. And then assessing the APGARs at 1 and 5 minutes on the mother. So 2 important things I think to take away from this whole algorithm. Number 1 is that the mother's body becomes the environment for assessment and care of that baby, as opposed to a warmer bed or any other place. So it's really the mother surface that is your surface for keeping the, and then anything that you need to do for that baby is done with that mother in contact. The second thing that's really important, and I think has drawn a lot of attention because skin-to-skin care was actually something that mothers really liked, that was easy for hospitals to implement because the feedback is so fabulous, but really fraught with some issues when there's discontinuous monitoring. So that you can't just place the baby skin to skin and leave them alone. We used to say, oh, just place the baby skin to skin and leave them alone. We didn't really mean leave them alone. The continuous observation is important. Now, that doesn't mean to take vital signs every 15 minutes. It's really just looking at the baby's color, looking at baby's respirations, and assisting and supporting to breastfeed when moms need help. So how do you make this happen? Well, the best way is through quality improvement, the standard PDSA cycles, and really putting in place a small test of change. So a willing mother who's delivering, a willing support person, willing staff, willing OB, willing pediatrician. Everybody has to know what's going to happen. You test it out, see what worked, see what didn't work, and learn from it, and then run it again. So these small tests of change, every hospital does it a little bit differently, and you have to see what works for your hospital. Rooming in. Rooming in is really something that is completely consistent with contemporary models of family-centered care. I mean, I think that in PEDS, we've actually come a long way in actually doing family-centered rounding and education. And this is happening on the PEDS floor, but really this could be happening in the mother-infant unit as well. And we've begun to do that with great success. We don't have a, quote, nursery. We have places where sick babies go, neonatal observation units, but the main place where our babies can be found is what we call the MIU, the mother-infant unit. And this is really a way to allow staff to have more frequent communication. Really, the pediatrician doing the exams in front of the family members is the best way to provide teaching and really improve health outcomes. And there's great literature from like Allison Holmes up at Dartmouth, who actually received the AAMC award with the innovation of providing skin-to-skin care and rooming in for babies that are actually undergoing NAS, which has become an epidemic everywhere. So this is something to consider for all populations. So the dangers of the nurseries are actually well studied in that mothers actually tend to sleep with poor quality and no longer than if the baby is removed and taken back. So moms actually sleep fine when the baby is right next to her. In addition, we advocate for cue-based feeding, and so it's really hard to do that when the baby's someplace else. And we do everything. We do the exams, the procedures, the baths, and moms leave essentially without having developed any level of competency, and that's particularly important for new moms. So think about what used to take place in the nursery that now is taking place in front of mom, and that's okay. It's just a different way of framing the care that we always provided, but now we're doing it in front of mom. And we're assisting mom in actually making optimal choices. And so the other thing we have to consider is that we recommend continued skin-to-skin care in the mother-infant unit, but what are the potential risks and what can be done to minimize those risks? So we know moms are exhausted after delivery and that her sleep is going to be in spurts, and we just have to be able to establish appropriate guidelines that recognize that skin-to-skin care is good, but if a mom is sleepy, then she has to be able to place that baby on a separate sleep surface, as opposed to having the baby sleep with her in a hospital bed, which is not safe for several reasons. Certainly all the literature looking at the dangers of bed sharing, but also issues related to hospital beds and falling from those beds, so it's not really a safe sleep environment. So while skin-to-skin care should be encouraged, moms should be encouraged to also use call bells and to ask for assistance if there's no support person there to support her to place that baby in a safe sleep environment for sleep. And this is just a case that was published. There's many more cases like this of a sentinel event with a mother who was advanced maternal age and delivered a healthy baby, but by cesarean delivery, and was breastfeeding in a sideline position. She fell asleep, and ultimately the nurse found the mom sleeping and the baby lifeless. So, so in these situations, maybe what would have been better is if just the breastfeeding episodes were actually observed in that mom who was excessively exhausted and really had limited mobility because of her cesarean. So as every hospital does with these sentinel events, you undergo root cause analysis and try to figure out what the problems are. In this particular hospital, the baby was resuscitated but had neurological impairment. And it was really through this collaboration of doing the RCA that the hospital was able to establish a better policy and procedure for prevention of this problem in the future. And so what they recognized is that, in fact, they needed better orientation and training of their nurses to couple care. They had just done it without appropriate education. They also identified that mothers that deliver by cesarean may need special needs, and then the mothers and the nursing staff, the mother nurses and baby nurses, participated in the development of a decision tree diagram. And you can get there first from this fishbone diagram, where you have this sentinel event, and then you work backwards and you look at all the different components of the system and look at the factors that might have contributed. It's not one person, it's not one staff member, it's not one policy, and it's not one place. It's often a whole variety of things that go wrong. And in your decision tree for rooming in, you might add in the level of fatigue or sedation, whether moms are on medication, their level of disability if they've had cesarean deliveries, and sleep deprivation. You know, how many hours were they awake in labor before delivery? And then provide solutions for at-risk couples in that case. And in this particular hospital, they actually developed a newborn safety sheet with informed consent that the mom and dad signs, and they understand the effects of pain medication. Staff is aware of maternal medications, and really effective use of call bells, and make sure that those call bells work. And then also adding in snuggle time so that moms and babies can have time to sleep where they're not going to be disturbed, so that babies can be sleeping in the bassinets next to the mother's bed, and there's limited visitation and limited procedures, limited hospital staff that can enter the room during that time so that moms can catch up. These are a couple of additional methods of addressing sentinel events, such as failure mode effects analysis and process maps, looking at staff and doing checklists. These are all useful tools that are really all throughout the patient safety literature. So staffing roles, you will identify this through process mapping, and what the AWON recommends is there be no more than 3 couplets to one nurse, so 6 patients for one nurse. I know that many hospitals violate this recommendation, and I would just say that that's probably not a safe situation. It's just impossible to be able to provide adequate care, because you're really not just caring for the mothers, and the mothers are then caring for the babies. Really, rooming in care means that the same level of care that used to occur when the babies were all cohorted together in the nursery is still being provided at the mother's bedside. It's almost like a semi-partial room. So I think that that's the way to look at it from the nursing staff. And then all staff that's involved needs to be educated and trained in how to provide breastfeeding support, and they should be documenting their skill levels. There's also an emerging literature about falls, baby falls, moms dropping babies, and then maternal falls. And there's literature from other parts of medicine that have been helpful in elucidating some of the recommendations about reducing cases of falls. And this is just one from the Oregon Patient Safety Commission, identifying falls and with recommendations about contracts with families, and then spreading information throughout the system about how to monitor mothers that might be most at risk for falls. And finally, there's some evolving literature that I thought I would just present. The first is, given the difficulty, particularly in moms that have had cesarean deliveries, in getting babies back and forth from skin-to-skin care to the bassinet and doing Q-based feeding, there's a study that's now been funded, so we'll be excited to see what the outcomes are. And we sort of alluded to this in the clinical report, that the sidecar bassinets may be available more and more in a safe manner in the U.S. And so Kristen Tully from UNC is going to be studying the effect of using these sidecar bassinets to try to improve safety in the hospital setting. Hats versus no hats, the literature kind of goes both ways, so it's really patient-parent preference. Certainly there's the risk of suffocation if the hat has any sufficient movement and can obstruct the airway. And finally, there's a whole swaddling debate. It is just tradition, if nothing else, that all babies in hospitals get swaddled. I think a lot of that comes from the fact that they were all cohorted in nurseries and made for a much quieter nursery, keep babies all swaddled. I've seen continued nurseries swaddled babies placed not on the back, and that should just not be done anymore. So if the baby swaddles in a nursery, they should definitely be on the back, not on the side. But really, there's a debate about whether or not swaddling is a good thing. Could decrease startling and arousability, so that may be one factor related to SIDS, and we just don't know if that's in a specific cohort of patients that have a risk or vulnerability towards SIDS. So in conclusion, the Baby-Friendly Hospital Initiative is in fact the safest way to care for mothers and newborns. And if you plan for these adverse events, you can in fact avoid them. Staff training is critical, and documentation of those trainings and their skill level is important to see how well staff has actually taken up the trainings, and the training should be interdisciplinary, use folks at all levels of the healthcare system, and there should be accountability. So charting should actually permit you to track and see whether or not there's gaps in specific areas of patient care. Don't change everything at once, because that's when disasters happen. Use the PDSA cycles, and then once you have a cycle that is really refined, once you've tested it out a lot of times and tweaked it, then it's time to ramp up and implement it in more settings, more times, more patients, even across hospital systems. If you don't plan for the unexpected, you know it's obviously going to happen. And then lastly, since I'm from Philadelphia area, I can quote Ben Franklin, and really well done is better than well said. You should be able to see when it's all going well. So I'm going to open it up to questions now.
Tammy, this is Amy. I have a question I can start with.
Okay, go ahead.
just to get things going a little bit. Thank you for that wonderful presentation, Lori. I really liked the fact that you commented on the more recent research that is coming out in some groups where this isn't as safe as we say it is. And I liked your explanations. However, I wanted to ask if you have any additional suggestions of how those of us who really are encouraging breastfeeding, and yes, people need to be watched. It's not like leave them alone and let it just happen. But, you know, we do have positions coming out from, you know, very highly thought of physicians that still say there's emerging evidence that compliance to the 10 steps of the initiative may inadvertently be promoting potentially hazardous practices and having counterproductive outcomes. And what kind of suggestions can you give to us in the listening audience for trying to start to turn around these? Because once something is published, and you know, a study is as good as whatever has been reviewed for it, but once it's out there, there's still people that are going to believe this, and they're going to spread that information, and it certainly makes it more difficult for us to move forward. What other suggestions do you have for those of us when people start coming up and waving these papers and positions in our faces?
Yes, yes. So, great question. I know there's been some publications, editorials really, in JAMA Peds regarding the safety of the 10 steps and baby-friendly. And what I would say is that there's no evidence that SUPC is rising in incidence. All we can say is that because of the quick adoption, or the more rapid adoption, should I say, of the Baby-Friendly Household Initiative in the last few years, certainly, you know, one huge push was the initiative that I was a part of with NICHQ. More attention is being focused on the 10 steps, particularly the early skin-to-skin care, rooming in care, as being a potential reason for these events to occur. But there's no evidence to suggest that, in fact, the denominator is any different, that these events are more common now than they were in the past. That said, the ways to avert these problems, such as SUPC or unsafe sleep practices, is to do exactly what I said. So there's the focus on the immediate postnatal period. And I talked about the golden hour, but really, in fact, the best way to, quote, transition babies is to observe, if the hospital can do this, to observe that dyad for the first 2 hours in the LDR, or, you know, it's an LDRP, then the baby stays there anyway. But if it's an LDR setting or just a delivery setting, then the best thing to do would be to actually keep the babies, allow the babies to stay skin to skin, not only for the first hour, but really for the first 2 hours there in that location with the OB nurses, and closer to more intervention and personnel and just a different monitoring method, then the mother-baby diet's then going to move over to the mother-infant unit. So many of the hospitals I've worked with have actually changed to that process. And that's why I said process mapping helps us. So process map is where you start from time point 0, you know, where the mother comes in laboring. And in that process map are all the different decision trees that are going to occur throughout that entire process, where she goes, what happens, what are the questions, what are the possibilities, and who's involved, until the point at which, you wave goodbye and mom and baby go home. So using that process map can help you figure out where the care is best served. And in many of the places that I've helped, including our own hospital, we found that just keeping everything together for the first 2 hours is probably the best way to go, so that you can get everything done. And that's true because that gives you time for the babies that are on the hypoglycemia protocol because of being at risk. For the SGAs, the LGAs, you can do the weights after the first hour, and everything's all right there. And so the people that know the weight, know how to respond and can initiate whatever protocols are then involved. Certainly the IDMs, or infants of diabetic mothers, that we know are going to be on the hypoglycemia protocols, they're going to probably take some supervision, and it's probably best to not ship them off to the mother infant unit quite yet. So that's one recommendation. I would go box 1 from the clinical report in terms of the steps of what to do following delivery. And then really the mother-infant unit, what happens in the room, I think is evolving. I think that it's an important message to send to provide continued skin-to-skin care and continued breastfeeding, but to have a very low threshold for having staff intervene if moms are sleepy, or if she needs assistance for that breastfeeding, or to just continually keep surveillance so that moms aren't falling asleep with their babies in the hospital beds with them, because that we know is a dangerous situation. But honestly, that's not any different than if the babies were in a nursery and brought out to breastfeed. So it's not as though that situation wouldn't arise just because of the rooming in, step 7. So before everybody sort of becomes all reactionary and decides to abandon the 10 steps in the BFHI, which we know, and I hope I provided some evidence to convince everyone, is evidence-based. The Baby Friendly Hospital Initiative is the best way to care for mothers and babies, and what we were doing was not good either, and probably worse, and definitely worse in many ways. And so we just do this in a way, and making change is always fraught with some difficulties too, because you're doing something new that you're not accustomed to. So anytime you try to do something new, you're not as skilled and not as careful, and you don't know all the nuances. So that's why doing it slowly using PDSAs is probably the best way to go about it. So having staff now be able to monitor a baby, if they're now cross-trained and they weren't before, having that happen slowly and methodically, and in a way that there can be some supervision, I think is much better than just saying, okay, as of October 1st, every baby's going to be rooming in. I mean, that's the kind of change that's always fraught with more concern.
All right, cool.
So the question is, step 3 focuses on prenatal breastfeeding support, yet physicians resist this, saying they don't have time to do this. How have those you've worked with overcome this challenge? Well, that's a great question. So it doesn't take time is my message. It really doesn't take time. You're talking to mothers anyway, and you can be providing this education while you're examining the mom. You just have to kind of do it in small chunks. So hopefully, I mean, we have a huge problem. I work in Camden, New Jersey, so we have a huge problem of low or no prenatal care. So, we have this mantra of seizing the moment, doing everything you can in one setting. So that's hard because, you have to provide all the prenatal care, all the different elements of care and education, sometimes in just 1 or 2 settings. But it is vital that the information come from the physician. That's who moms really want to hear it from. We just had a student actually do a 4th-year quality elective, and she participated in doing the audits in the prenatal setting. And it was overwhelming to hear the number of questions that the moms had that they would have otherwise left the prenatal setting never having answered, and that are easy questions to address. I think there's just, moms are not empowered in these settings to ask the questions of their providers. Providers, I hate to say it this way, but are going to be scrutinized more and more about that. So CGCAPs will ask about whether providers are answering those questions that families have and answering them in ways that patients can understand. And it's all about communication. Really, everything about quality and healthcare and patient satisfaction is all about communication. So if you're trying to improve your CGCAP scores, doing this and having the conversations with families about the 10 steps, recognizing what skin-to-skin care means, what rooming in means, the benefits of breastfeeding, the risks of formula supplementation for breastfeeding mothers, really having those difficult conversations and not being judgmental, and sort of being very matter-of-fact about it, and just with the expectation that most mothers will want to breastfeed, you will find that mothers are really excited about talking about it. They have questions. They're just always afraid to ask, and they don't know who to ask, and they often have misinformation. And what a wonderful thing to be able to do as a physician, but correct some of that misinformation. So empowering, and you will find that mothers will make a greater connection. You may actually improve the rate of adherence to prenatal education because you've provided what moms want, which is answers to their questions. Often healthcare providers tell us they don't want to make mothers feel guilty so that they aren't comfortable addressing breastfeeding to this degree. What would you say to your colleagues to that? So it's all about how you frame the question. I mean, mothers are going to feel guilty about any number of things, but moms don't want their questions to go unanswered. They just don't. They feel, I think, discouraged when their healthcare providers don't give them opportunities to have a conversation. You know, I think that you can say something like, tell me about what you've been thinking in terms of breastfeeding. And have you heard about the things that breastfeeding does for your baby and for you? And have you heard that, you know, formula can make that worse, and how it can undermine and be a risk for your breastfeeding? And what have you heard, and what do you know about it? And that's really everything that we have been teaching in regard to motivational interviewing, which is this different kind of conversation where you sort of sit on this neutral plane and you just see where families and patients are coming from, and you try to correct any myths or misunderstandings and just move patients kind of along the plane of behavior change so that they slowly adopt the behaviors that are best. So it's just practice. And what I would say is the best way to do this is role play and just practice. Yeah, so the official stance is regarding preemies, so they have not really had any official stance on, I hate to call it delayed, appropriately timed cord clamping, on healthy term newborns other than what's in our clinical report. So if you look at step number 3 under box 1 in the clinical report, I'll just read it to you. It says, if the newborn is stable, place skin to skin with cord attached with option to milk cord. Clamp cord after 1 minute or after placenta delivered and reassess newborn to permit physiological circulatory transition. And that's cited. So this is now the official opinion of the American Academy of Pediatrics. As a clinical report, it's not a policy statement. Policy statements occur when there's more robust evidence, more level 1, at least some level 1 evidence, at least level 2 evidence. And really, because this is kind of an evolving field and really a response to a lot of the concerns that I'm sure you've all heard about, we felt that it was important to assemble what we do know and make recommendations for what we believe are best practices, but they can't be interpreted as AAP, quote, recommendations until they're codified into policy statements. And hopefully that'll happen, when the evidence is sufficient. But I would say that, you could use this to say this is the voice of the AAP.
Great. Well, if there's no more questions, I think we have done this session really well. And I would like to thank Dr. Feldman-Winter for her time and for her expertise in this and sharing it with us, and for being our lead kickoff for this physician webinar series. And we hope that those of you joining us are available to view and listen to some of the future sessions that we have planned. Thank you.